Good morning. We're on a tight schedule today, so we're going to get started here. Yesterday afternoon, when after a number of speakers expressed the feeling that current U.S. drug policy falls somewhat short of perfection, we were asked for suggestions of alternative measures that might prove more effective. We got some responses to that suggestion yesterday afternoon, and we're going to try to get even more today. As we shall see, not all nations subscribe to the proposition that prohibition and zero tolerance are the only viable responses to drug use and abuse and their attendant problems. And we have a remarkable opportunity this morning to consider how some other nations that we in America generally admire and think of as not all that different from ourselves, are dealing with this complex issue. This afternoon, we will consider ways in which American drug policy may have unintended consequences for other nations, and of course that will be doubtless part of the discussion this morning as well, and how it may even stimulate the very responses that we desperately want to avoid. My name is Bill Martin. I'm a senior scholar at the Baker Institute and the primary organizer of the conference, although obviously I've had an enormous amount of help from a number of other people here today. Happy for you to be here. Happy to welcome the people who are watching this on the webcast, and we have a good audience for that. These proceedings will be archived on the web through the www.bakerinstitute.org for a long time. So those who would like, people who you feel would benefit from this, within a couple of weeks at least, this will be available for anyone to watch at leisure in the parts that they are most interested in. This morning, our first speaker is not with us, but he has made a superb effort to simulate being with us. Mike Trace is the UK Deputy Anti-Drugs Coordinator, and he has played a pivotal role in implementing the British government's 10-year Tackling Drugs to Build a Better Britain program. He's also the chairman of the board of the European Monitoring Center on Drugs and Drug Addiction. And the center, with headquarters in Lisbon, was set up in 1993 in response to the escalating drug problem in Europe and to demands for an accurate picture of the phenomenon throughout the European Union. So even though Mr. Trace is from the UK, he's in close contact with drug use throughout Europe and is an ideal person to start our discussion this morning. As I say, he's not able to be with us, but he went to a good bit of trouble to produce a video that we will show, which he's just done in the last few days, and we will then be able to converse with him via telephone hookup. So just as if he were here, but invisible, let us welcome Mike Trace.
Sorry I can't be there, but I hope this video is a useful substitute. I'd like to thank the organisers for giving me the opportunity to speak to this audience, and particularly thanks to Bill Martin and Bill King for making this technically possible. I'm going to speak to you today as the chair of the European Monitoring Centre on Drugs and Drug Addiction, which is the European Union's drug policy agency. But I was also for 4 years the deputy to the UK drug czar, in which role I was involved in setting up the United Kingdom drug strategy, which was launched in 1998. And I'm currently involved in its implementation, particularly the treatment and harm reduction aspects. In Europe, we have an agreed approach to the drug strategy in terms of setting objectives and measuring progress against those objectives. And this agreed consensus on broad approach actually masks some real differences in how to meet those objectives. Different countries have different approaches and different beliefs of what the best activities and policies are, but we do agree on what the broad objectives should be. I'm going to use this speech to outline how that approach works and also give some examples of how European member states are working towards those objectives. I will also, towards the end of the speech, give an update on some of the issues within Europe that your organisers felt that may be of interest to your audience. There's been significant progress over the last few years in the development of coordinated drug strategies. Before 1998, only a few countries had explicit strategies that set out the objectives they were trying to achieve and the actions they were going to undertake in order to try to achieve them. The US, for example, has had a written drug strategy that covers all elements for many years now. The UK, we launched our first meaningful coordinating strategy in 1998. Now it could be said that most national governments, certainly in Europe and the developed world, have these integrated strategies, and the ideas behind them and the objectives behind them are now bedded into international agreements such as the European Union Drug Strategy and the United Nations action plans launched at the special session in 1998. Each of these are working towards an agreed set of 6 objectives that are fundamentally underpin drug strategies. And these 6 objectives are reducing the availability of drugs, reducing the prevalence of the use of illegal drugs, particularly amongst young people, reducing the public health damage associated with drug misuse, particularly there we're thinking of infections such as HIV and hepatitis or drug overdose deaths, reducing drug-related crime, either associated with drug markets or crime committed by drug addicts who are trying to raise money to buy their drugs. Reducing drug-related social exclusion. We know this is an important aspect of policy, very hard to define, but the impact of drug use on somebody's inclusion in society is very important. And finally, increasing access to drug treatment for those who have developed a problem. Now these 6 objectives are written into most national and international agreements now. Some of them are easy to define. And easy to count. For example, prevalence. We now have agreed methodologies worldwide on how prevalence can be established and how it can be counted. And household surveys and school surveys now have given us, European countries and the US and several other countries, a data set which we can see trends and we can make comparisons between countries according to defined methodologies. Also with drug-related HIV infection, there is a good data set to track for many years now of the rate at which people have contracted HIV related to their injection of drugs. Some of them are much more difficult to conceptualize and count. Here I'm thinking about drug-related crime. There's no agreement in Europe of exactly what the definition is of drug-related crime, and certainly no method of monitoring and comparing the data from each country. Similarly, on social exclusion, we know this is an important policy issue, but we have no current method, agreed method internationally of defining it and counting it, and this is important work for the future. But given these difficulties with methodology, at least we do have one area of consensus, which is what are the 6 key objectives of drug strategies, and as I say, those are embedded quite clearly now into international agreements. So the key question is, if those are the agreed objectives, what are the policies and activities that are most effective in meeting those objectives? And this is where countries begin to disagree. Some countries emphasize the prevalence and supply objectives, reducing the prevalence of use and reducing the availability of drugs. And this is the case in the European context, particularly of countries like Sweden. And it, of course, underpins most of the USA drug policies of recent times. In this paradigm, then basically the most important objectives and most of the resources go towards reducing the level of drug availability and drug use. To contrast with that, some countries are emphasizing the reduction of the harm related to the drug use. They spend less time trying to reduce the prevalence and actually try to address the consequences, and most of their resources go towards addressing the consequences. This has been most explicitly the basis of Dutch drug policy, where they have said that they acknowledge that there's a large amount of drug use in their society, but they concentrate on reducing the public health damage, and that has been the avert intention of their policy for 25 years now. In the UK, more recently, the most important emphasis in our policy is the reduction of drug-related crime. We have some very good evidence in the UK to show the extent to which property crime is committed by people to raise money to buy drugs, and that is the top line priority of our current drug strategy, so to reduce the consequence of crime related to drug misuse. As there is no clinching evidence or proof worldwide of what is the most appropriate or the most effective approach, policy-wise or in terms of actions, you can expect that there is an awful lot of debate about the relative merits of these two approaches. However, there are some clear conclusions that can be drawn from analysis of effectiveness of particular programs in a European context. I'll give you some examples now. In the UK strategy, in 1998, we had very good evidence of the concentration of crime and health damage that was related to the heavy-end drug users, if we could say. I think in American terms these would be called the addicts or the hardcore users. And most of the health damage that was, health and crime damage that we were experiencing was related to the relatively small numbers of very heavy users. We also had some pretty good evidence from UK statistics and international work of the positive impact of good quality treatment targeted at this group. The result was, a major element of our policy launched in 1998 was a big drive to expand the investment in good quality drug treatment, to improve our treatment system. It was very previously underdeveloped. We had situations through the 80s and 90s where it was quite normal for people to have to wait to six to 12 months to get into drug treatment. So we had a ration system and an underfunded system. We're now in the middle of a program of expanding the system and improving its effectiveness. And 2 years in, we're already showing impact. Where treatment is effectively delivered to the right people in the right way, we are having a significant impact on the health problems they're facing and the crime they're committing. We also continue to invest in the prevention and supply reduction aspects of the strategy. We try to keep that balance, but the prime aim is to improve our treatment to reduce the crime and health problems. Another example comes from Sweden. In Sweden, there has been low historical prevalence of particularly heroin use. And the view of the government there has been consistently that maintaining this low prevalence is the most important objective of their drug policy. As a result, they've had an emphasis on primary prevention to encourage or discourage young people from getting involved in drug misuse. That has received a significant part of their investment in Swedish drug strategies, and that has been reaffirmed as a result of a review that they've just completed. And it's certainly the case that Sweden remains one of the lowest prevalence countries in Europe. It is still low, it is rising, and it's very interesting to see where the prevalence rates in Sweden will go in the next few years. In the Netherlands, in contrast, there has been, as I mentioned earlier, a strong commitment to public health measures. So most of the investment over the last 20 to 25 years has been in ensuring that the public health consequences of drug misuse are minimised. And that means a strong investment in extensive drug treatment services, particularly low threshold services like needle exchanges and prescribing services. And the result does seem to be that the rates of drug-related HIV and other health problems have been kept low. So the Dutch government could claim to have success according to the objectives that they have prioritised. Now, as I mentioned earlier, the European Monitoring Centre on Drugs and Drug Addiction, based in Lisbon, is tasked with gathering data on each of these initiatives, looking at the effectiveness of particular programs and the policies that within which context they work. A key review for the Monitoring Centre and also worldwide will take place during 2003. For the first time, all of the national governments and the European Union and the United Nations will be looking at the progress against the objectives I mentioned earlier. In the context of Europe, that is the midterm review of the European Union Action Plan, which runs from 2000 to 2004. In the context of the UN, this is the midterm review of the 10-year action plans laid out at the special session in New York in 1998. So for the first time, we're going to get a chance to formally look at which policies and which programs are making best progress towards the objectives we've all agreed on. I also said that I was going to talk about a few topics that we were estimating would be of interest to this audience. There are a number of particularly controversial topics in European drug policy at the moment, and I want to give you a few words on what is the current state of play with them. First thing I want to look at is heroin prescribing. This is the practice of doctors prescribing pharmaceutical heroin, which we refer to as diamorphine, to addicts to enable them to avoid having to buy it on the streets. Now, this was actually the substitute treatment of choice in the UK throughout the 1960s. Very small scale, the numbers of patients never exceeded 500. But this was the drug of choice, if you like, for doctors during the 1960s. There were concerns about overdose relating to this prescription, and particularly leakage onto the black market, which became a problem in the late 1960s. So in the UK we changed our primary substitute prescription to methadone, which has been the main drug in our country and others since then. There are small numbers have continued to be prescribed on diamorphine up and down the country, and we did have a situation in the northwest of England during the 1980s where a particular doctor, John Marks, had the view that this practice should be widespread, so had many patients on diamorphine. When John Marks stopped practicing, then it's remained quite a peripheral choice of treatment in the UK. The shame in that is that we've never actually gone through in the UK, with all that experience, we've never actually evaluated or developed good practice guidelines on the use of diamorphine as part of the treatment package. So we don't have an evidence base that we could actually lend to the rest of the world. But clearly it is a workable treatment option, just as methadone treatment is, or buprenorphine, which is another substance used for the same purpose. More recently, Swiss governments and the Dutch governments have engaged in running clinical trials using diamorphine, and this has attracted much attention, and it's of great interest to see the efficacy of these. Other countries, Spain, Portugal and Germany within Europe, are looking very seriously at running their own trials. Broadly, the results of the Swiss and Dutch experiments at the moment are positive, but they're in very controlled, research-based context. The UK government are looking again at our use of diamorphine and whether the current 400 to 500 patients who are on diamorphine is the appropriate level within our treatment system. We're looking at the appropriate place for diamorphine within a much wider treatment system, and I think it's fair to say that we don't view diamorphine as a mainstream treatment, but we do want to look at its use for particular target groups or particular settings. One of our problems with our methadone treatment programs is there is definitely a cohort that does not comply well with methadone treatment who may comply much better with diamorphine treatment. There are two schools of thought on what the target group should be for diamorphine prescribing. One is what we refer to as the old-timers, people who have been in and out of treatment for 10 or 20 years who are not managing to stabilise on any of the treatments being offered to them. And maybe the best approach there is to say, okay, let's give them their drug of choice to keep them stabilised in the only way we can do it. Another thought is entirely the opposite, is that diamorphine prescriptions should be targeted at the most young and chaotic users as a way of getting them into treatment, and this is definitely a cohort of people who it is very hard to attract into treatment. So at the moment within the UK we're looking at that, and within Europe as well, we're looking at those issues and whether that the prescription of diamorphine is more valuable for those groups than the current reliance in our country on methadone. Second item I'd like to look at is needle exchange. This is the practice, I'm sure you're aware of, that of dispensing clean needles through drug projects or pharmacies or hospital settings to addicts to avoid the practice of the reuse of needles or the sharing of them between different individuals and groups. This was introduced for the first time in the mid-1980s in Europe, primarily in Netherlands and the UK, as a response to fears about drug-related infections, particularly HIV. It was introduced much later in countries like France, Spain and Italy, for example. Clear evidence of the major impact that needle exchange has had on HIV infection has emerged in Europe over the last 15 years. The HIV rates related to drug misuse are significantly, in fact radically lower in countries such as Netherlands and Britain than they are in Mediterranean countries, Spain, Italy and France. And this can be tracked quite straightforwardly to the speed with which these measures were introduced in the mid-80s. It's important to say that needle exchanges have had a much lesser impact on rates of hepatitis infection, which is a much more robust infection. And also, there are many management problems with the introduction of needle exchanges, particularly in terms of neighbourhood management and relationships with the law enforcement authorities. But it is pretty well established in European drug policy now that needle exchange is a very important part of public health measures around drug misuse, and they should be introduced as part of a package that includes a lot of health education and low threshold entry into treatment. And the evidence base that shows that these approaches do have a significant impact on the health damage caused by injecting drug misuse is well accepted in Europe now. There's a suggestion from some circles that in terms of next steps, there are related projects that can be introduced to reduce drug-related overdoses, and this is definitely a problem in Europe. UK particularly has a worrying number of overdose deaths related to heroin and other drug use. Our rate is over 2,000 deaths of young people per year in this way. One of the ways put forward to reduce these figures are injection rooms, and what this is the creation of a facility which allows drug injectors to take their drugs, i.e. Their injections, in medically controlled circumstances, so that should an overdose take place or should any medical attention be required, there are nurses and facilities on the spot to make sure the overdose does not become fatal. Now, these injection rooms have been implemented formally in Australia, in Germany and in Spain, and much less formally in many other countries. It's got to be said that some needle exchange facilities have what is almost an injection room attached, where many users are allowed to inject on the premises. But the formal attempts to introduce injection rooms are all being very closely evaluated in their country, and the Monitoring Centre is doing a review of the evidence for effectiveness of injection rooms, and will be bringing out a report towards the end of 2002 on the summary of such effectiveness. The next item that always causes controversy is enforcement of laws on cannabis. In Europe, most European Union countries, like the US, have reasonably high rates of prevalence of cannabis use. Large numbers of particularly young people in our societies make the choice of using cannabis. All of the countries in the European Union do not fully enforce the laws that they have on cannabis possession and use, and these are the laws that obviously are expected of us within the United Nations conventions. To illustrate this, for example, I give the UK. We estimate we have 3 to 5 million users, current users of cannabis in the country. We arrest, on last year's figures, 60,000 people for the offence of possession of cannabis, so a very small proportion of all the users in the country. And 55% of those that we arrest, we give a caution, which is a warning administered at the police station. So basically a warning, and then the individual goes free. What this means is basically that the vast majority of cannabis use goes unenforced and goes unnoticed by the authorities. Same situation in, for example, Netherlands and Spain. There is official tolerance of cannabis use. It is the official policy that somebody will not be arrested for the possession or use of those drugs. And as you know, in the Netherlands, that has extended to the opening of coffee shops. In Italy and Portugal, they have official policies of responding to cannabis use with administrative sanctions. In Italy, this has been embedded into their policy for many years. In Portugal, they introduced this policy last year, not just for cannabis, but also for all other drugs, including cocaine and heroin. Recent attempts, the trend in Europe recently has been attempts to try and make sense of this dichotomy between policy and practice, and mainly to bring policy in line with the practice of enforcement on the streets. For example, Belgium has a current debate within its parliament where the government is recommending that guidance is issued to enforcement authorities not to prosecute on possession or use of cannabis. In Switzerland, there is a proposal in front of Parliament on official tolerance of possession and cultivation of cannabis. Particularly the cultivation aspect of this is interesting and has brought the Swiss authorities to the attention of the United Nations. But the thinking of the Swiss government is that they do not want to create a broader market for cannabis that is then met by criminal organisations. So they are considering positively encouraging small-scale cultivation of cannabis within Switzerland. And in the UK, there is a proposal in front of the Home Secretary at the moment to reclassify cannabis from Class B to Class C within our legislation, this would make it a non-arrestable offence, and within our police priorities would seriously downgrade the place of cannabis, and it's reasonable to assume that if that action was taken, then the 60,000 arrests that I referred to earlier on would not take place. The motivation behind the UK initiative is not any great moral position or public health position. It's an argument about police resources. We look at the amount of resources that are spent on arresting and prosecuting cannabis users, and we think that maybe there are other more pressing priorities for our police to follow. And it's got to be said that one of the pressures on our Home Secretary is that public opinion is very strongly in favour of that approach. But with ourselves, as well as Belgium and Switzerland, these are issues being considered rather than changes that have already been made. Final thing I'd like to talk about is medicinal use of cannabis. There's been long-standing research in the UK into the effectiveness of cannabis as a medicine for certain ailments, particularly multiple sclerosis, the nausea associated with cancer treatment or HIV treatment. And it looks clear that this research, although it is ongoing, but it looks clear that this research will give a positive outcome and will recommend cannabis-based products as a medicine for some of those conditions. It's hard to predict, but that could lead to these medicines being licensed within the UK within 18 months, formally agreed as drugs that doctors can use to prescribe to those patients. It's important to remember that even if such a license is given and cannabis products do become a medicine in the UK and by extension in other countries, that does not mean that that permission is given to people to self-medicate, i.e. smoke their own cannabis for medical purposes. What it is the production of a pill or an inhaler with cannabis-based products in it. And there'll be conditions on the method of prescription of it, the mode of supply of the drugs. Obviously doctors are not going to be encouraged to prescribe anything that can be smoked. And also the ailments for which it can be prescribed. Multiple sclerosis, as I mentioned before, but also back pain. In the UK, the position has been challenged, which I understand has been challenged many times in the US, of individuals who, when taken to court for cannabis possession or use, claim that they are taking it for medical purposes. And I think pretty much the same in Europe as in the US, that is not been agreed by the courts as a valid defence. But obviously, once again, there's a strong public opinion reaction to that, where people are seen as victims of those elements, and the authorities are seen as over the top in trying to prosecute people. So that's the research that's going on that issue in the UK. Other European countries are watching it very closely, and the policy implications of that are going to have to be very carefully weighed up in the next 18 months. I hope these examples give you some insight into the current state of policy and debate around drug misuse in Europe. I'm grateful for the opportunity to speak to you, and I wish you all the best for a successful conference. Thank you very much for your attention.
Thanks very much, Mike. Can you hear me? Are we hooked up with Mike Trace? Good. Hear you just fine. Thank you for doing that. And we're all very admiring of your dexterity with a water glass. Well, it was the speed with which you were able to get through with that was just astonishing. No, thank you very much. We appreciate it, and you covered a lot of ground and did exactly what I'd hoped you'd be able to do in order to set the stage. And also, some of the speakers we have will elaborate on some of those points, but other places you have filled in nicely. Now, do we have some questions? Yes, Dr. Evans.
Yes, my name is Dick Evans. I'm a doctor here in Houston. It's my recollection, and conference participants are welcome to correct me if I'm wrong, but that at yesterday's meeting, that one of the speakers said that your program of supplying heroin to addicts had resulted in the doubling, 100% increase in heroin use in your country. Can you comment on the accuracy of that statement?
Particularly referring back to the use of heroin prescription back in the 60s and early 70s.
Right.
He didn't qualify it, but Bill, you can...
I think that is what he was referring to, yes.
I wasn't around this time, I didn't have policy or clinical responsibility But certainly, hello?
Yes, you're still here.
But certainly that growth of heroin addiction has continued through the 70s and 80s when we have had different prescribing policies. I think the main concern of the authorities in the late 60s was the diversion of the diamorphine onto the black market. I don't think we could claim that the policy of prescribing diamorphine created the addict. What it did do, though, is create the black market. It brought to our attention the need to control the method of prescription and the supervision of it.
All right, thank you. Judge Gray? This is Judge Jim Gray, who was one of our participants yesterday. Mike?
Good afternoon, and thank you for being with us. It's my understanding that in our country, the hemp industry has gone back to colonial times and was certainly prosperous and an ingrained part of traditional society. It's my understanding now that England is revitalizing that trade. Is that accurate, and are there any shots being accepted by Britain from the United States Department of State or otherwise to try to prohibit it?
Not sure we have an official government position on that one. We certainly do have shops that trade in hemp seed and hemp products, and within very carefully debated guidelines, that is fully legal in our country as long as it can be shown that the product is for agricultural use or product use rather than smoking or other use. I haven't seen personally a great trend towards the increase in that trade. I think the place that will be very interesting to watch in Europe is Switzerland because their attitude towards the positive uses of that drug in many walks of life. But I couldn't say that we've got a great explosion of trade in hemp seed for agriculture or other purposes.
Okay. Dean?
Yes. My name is Dean Becker. I'm an avid reader of the Guardian newspaper. I see so many signs of enlightenment coming from Great Britain. Thank you. It's been called a miracle medicine. I understand there are cannabis clubs being built across the countryside. We just recently celebrated 30 years of the Schaefer report, which basically said marijuana is safer than aspirin, a report which was quashed by President Nixon and has been held under by every administration since. And I wonder what made the difference in Great Britain. How were you able to recognize the truth and act upon it to, end the greater harm associated with the war on cannabis?
I think a good decision that was made in terms of medicinal cannabis in the UK was to place the issue of medicinal cannabis purely into the scientific domain, in the development of medicine domain. And that's taken a lot of the political heat out of it for us. We said that we develop medicines and the pharmaceutical companies develop medicines for all sorts of things. We have a very well established process to allow these medicines to come to the market. We've applied exactly those rules to cannabis-based medicines that we would anywhere else. It's certainly true to say that the process that this particular pharmaceutical company has gone through with developing medicines based on active ingredients of cannabis, the results of their research so far are very positive. Obviously, they don't fully publish them because they're a commercial company, but everything we've seen has been positive so far. And the process of getting a license in the UK involves the building of a portfolio of evidence. And as I say, we're predicting that that portfolio of evidence will be put us in a position for licensing towards the end of 2003. But I think, if you like, what you refer to as the enlightenment, thank you for that, is that we are treating it as any other medicine and trying to take the politics out of it. And that is helping us to consider these issues separately, if you like.
Howard?
My name is Howard Woldridge. I'm a retired police officer. Has there been any reaction from law enforcement in Europe regarding these changes in the approach to drug enforcement?
Yeah, a number of responses. I mean, in some areas, the pressure to actually achieve that change is coming from law enforcement communities. I've mentioned, I think, in the presentation that in the UK, one of the strongest arguments in favour of reclassifying cannabis for recreational use has come from the law enforcement community. It's a matter for them of where they prioritise their resources. I'm sure it's the same issue in the US and within states of the US, but decisions made by law enforcement managers of where they prioritise the use of police resources. It's a constant, very difficult balancing act. And in the UK at the moment, there really is the only experience, long-term experience we have of whether that takes place or not is Holland. And of course, there is completely evidence coming out of Holland. There is evidence to say that there are much more tricky Class A drug markets in organised crime in Holland than other places. And some people link that to their historical position on cannabis. There's also other indicators that say Holland is an easier place to police than any other equivalent city.
Right, we have room for one more question, about 2.5 minutes for question and answer. The question should take up less of that time.
Okay. My name's Bob Ramsey. I'm from the Dallas area. In my research of history of narcotic use, it always seemed that the percentage of the population that uses or abuses opiates ranges between 0.25% and 0.75%, which seems to be that the police would say it was 0.25% when they needed to say how good a job they were doing, and when they needed more money, they'd say it was 0.75%, and it has tripled. And I was wondering if your data would indicate what percent of any population in a mix of cultures has a predilection for narcotic or opiate dependency or abuse, or however you choose to characterize it. What percent of the population likes the stuff?
The data we have from the monitoring set is not strong enough to give us any clear messages on that. What we can say is I have said in our most recent annual report, is that irrespective of the cultural history of a country or irrespective of its legal position, the level of addiction across the board, and I think we have to consider illicit drugs, alcohol, and tobacco altogether in this, but the level of addiction does seem to be broadly similar across all of the different administrations. I broadly agree with your analysis. I think if addiction, the condition that displays itself through different drugs is what we're trying to respond to, then broadly there is a section of the population that has predisposition, and a section of that, subsection of that population actually going to active addiction at any one time. So I think broadly that's very important for policy analysis. In terms of the data, I don't think we cast all that much light on that in terms of the monitoring centre data yet. What we have is to say that rates of proper drug use, presentation, and treatment seem to not vary according to legal structures or cultural history.
Well, thank you very much, Mike. Well, I think we all appreciate and would be happy to show you our appreciation for your being with us by a long distance this morning. You've gotten us off to a good start, and I hope you'll come again.
Thank you very much.
Okay, thank you. We are going to keep close to our program this morning, and Dr. van der Linde has assured me that he has a very good Swiss watch that will help him. I trust the others also have trusty timepieces. And it's unfortunate because with all of these people, they could speak to us for much longer. Our next speaker, Alex Wodak, gets the long-distance ribbon for coming to be with us at this conference, and his effort is truly a testimony to his dedication to being helpful in dealing with these complex issues. Dr. Wodak is the director of the Alcohol and Drug Service at St. Vincent's Hospital in Sydney, Australia. He's also president of the Australian Drug Law Reform Foundation and president of the International Harm Reduction Association. He's a member of a number of state and national committees and often assists, as we were talking last night at dinner, often assists in helping developing nations deal with controlling HIV infection among injecting drug users. The title he's given his remarks for today is A Tale of Two Countries, the Response of the USA and Australia to HIV Infection Among Injecting Drug Users. Please welcome Dr. Alex Wodak.
Good morning, ladies and gentlemen, and I'd like to also pay my very grateful thanks to the organisers for putting on this wonderful conference and especially for inviting me, and I'm very pleased to be here. Firstly, let me begin by asking the question whether it is indeed appropriate to begin comparing the United States and Australia. To me, the similarities between the two countries leap out. The countries are similar in many respects, and these include the geography of the two countries, their history, climate, language, demography, the political systems, the economic systems, health outcomes, racial diversity, culture, many other aspects as well. But there are some obvious differences. The population of the United States is about 15 times greater than Australia. Income is about 25% greater in the United States per person. The prison population is about 700 per 100,000 in the United States and 100 per 100,000 in Australia, so 7 times greater in the United States per population. There is universal health care in Australia, like almost all industrialised countries, and that's, of course, lacking in the United States. And gun laws in Australia are strict, as they are indeed in almost all other industrialised countries, but not so in the United States. The last person executed for a criminal offence in Australia was over 40 years ago, so Australia has no capital punishment, again, like most other industrialised countries, but not so in the United States. Australia also has a very sad history, indefensible history of treatment of its own Indigenous minority, but it doesn't really compare with the tragic history in the United States of slavery and its aftermath and the tremendous racial disharmony which still prevails today and has such an impact on drug policy. My conclusion in all of this comparison is that the commonalities between these two countries far outweigh the differences, although there are some differences, in the general characteristics of the two countries. What about drug use in the two countries? Well, it may surprise you to know that the consumption of many mood-altering drugs in the two countries is quite similar. For example, alcohol consumption, tobacco consumption, very similar in the two countries. Cannabis consumption, if anything, a little bit higher in Australia than the United States. But cocaine use is very much higher in the United States than Australia by a factor of about 4. Thank you very much. Heroin and amphetamine use is probably slightly more common in Australia than it is in the United States, which may surprise some of you. Again, the conclusion from this very simplistic analysis is that the commonalities in drug use between the two countries far outweigh any differences. But when we look at the differences in HIV/AIDS, we see some remarkable differences starting to emerge in recent times. HIV entered the gay population, that is, men who have sex with men, in the United States in the mid-1970s, and the similar event happened in Australia only a few years later, and these events were linked because gay men in San Francisco and gay men in Sydney had a lot to do with each other, and so HIV infection in Australia arrived really through San Francisco, this gay population. From the gay population, HIV entered the injecting drug-using population very quickly in both countries. But HIV in the United States is now far more common than it is in Australia. There are 40,000 new infections in the United States every year. This is a conservative estimate, it's an official estimate, and it's one that's several years old. It's probably much higher by now. And there are less than 500 such infections in Australia, so this would be equivalent to 7,500 infections multiplied up to the size of the US population. At least a third of new HIV infections in the United States are attributed to injecting drug use. This is a conservative estimate. Many authors, official authors, place this around about 50%. And about 8% of HIV infections in Australia can be attributed in some way to injecting drug use, and that's a generous estimate. The usual estimate is around about 4%. The 8% refers to gay men who are also injecting drug users, where probably most of the infections are through sexual contact. The conclusion of all of this is that the rate of AIDS, that is the number of AIDS cases per head of population in the United States, per head of population, I emphasise, is about 6 times higher in the United States than it is in Australia, and that gap is increasing over time. Now let's run through some principles that are specific to HIV prevention among injecting drug users. In 2001, there were about 100,000 dependent heroin users in Australia, and the total number of injecting drug users of all drugs was about 360,000. So there's no shortage of people injecting heroin in Australia, and or injecting other drugs, and these numbers are alarmingly increasing at an estimated 8% a year. So we certainly have a very big problem with illicit drugs. But the response in terms of HIV began very early and has been very vigorous. So each year Australia distributes around about 30 million needles and syringes. And this number is increasing by about 10% a year, and that has been the case for many years. We have about 30,000 people in methadone, so this would be equivalent to 450,000 multiplied up to the US population size. And the number of people in methadone treatment in Australia is increasing by about 10% a year. HIV education for drug users is explicit, it's very realistic, and it's based on active involvement of drug users in the design and implementation of HIV education. We have a total of 9 organisations of injecting drug users who are funded by governments across the country. Now, if we compare this to the United States, there are about 30 million needles and syringes distributed in the United States, so roughly a comparable number to Australia, but of course the US has a much larger population. In contrast to the estimate of 100,000 heroin users in Australia, there are estimated to be almost 1 million dependent heroin users in the United States in the year 2000. And 205,000 are estimated to be in methadone treatment in the United States. This number is believed to be increasing only slowly. And most of the HIV education for drug users still has a just say no kind of flavour to it. And there are no government-funded drug user groups in the United States as yet. So if we summarise all of this, in the United States there are about 850,000 people living with HIV in the year 2000. In contrast, in Australia there were 12,444 people living with HIV. So if we multiply that up to the US, the size of the US population, that would be about 350,000. There are 308 people living with HIV in the United States per 100,000 population, compared to 68 people with HIV per 100,000 in Australia. There are 46,400 new AIDS cases in the United States in the year 2000, compared to 255 new AIDS cases in the year 2000. And looking at this in terms of incidence, that is, per 100,000 population, this gives us a rate of 16.7 new AIDS cases in the United States per 100,000, compared to 1.4 new AIDS cases per 100,000 in Australia. If we look at HIV diagnoses in Australia in the period 1994 to 2000, 70% of these were attributed to gay men. The group, a miscellaneous group of others, claimed 9%, injecting drug use 4%, and heterosexual claimed 17% were attributed to heterosexual contact. If we further look at the heterosexual group, we find that 28% of these came from high prevalence countries, and when we look at the partners of the remainders, we find that 19% of the partners came from high prevalence countries, 1% of the partners acquired HIV through medical means. The exposure was unknown in 12%, there were no details in 30%. Gay men were partners in just 4%, and injecting drug users were partners of these heterosexual contacts in only 6%. That's a very significant low figure of 6%. So let's look at the prison population in the two countries. In Australia, HIV prevalence, and here this is jail and prisons in the US context, HIV prevalence among male and female inmates in Australia was 0.1% in 2000. Now, the prevalence of HIV in the general American population is 3 times higher than this. So, in other words, the prevalence of HIV in the general population of the United States, about 3 per thousand, is about 3 times greater than the prevalence of HIV amongst inmates. The summary of all of this is that we have excellent control of HIV infection among injecting drug users and the general population in Australia, but sadly this is not the case in the United States. Now, AIDS incidence in Australia is, in the year 2000, is not unusual compared to other industrialised countries. And here you can see the rates of HIV infection among a range of other developed countries. 1.4, the figure I gave you already for Australia, 2.6 for France, 0.5 for Germany, 3.7 for Italy, to 7.2 for Spain, 1.1 the United Kingdom, 2.1 for Canada, and 16.7 for Australia. So Australia is not remarkable compared to other industrialised countries in terms of AIDS control, but the United States stands out as having, unfortunately, a very much bigger problem, and the poor management of HIV infection among injecting drug users is largely, not entirely, but largely responsible for these differences. Anyone who wants further information about the state of HIV/AIDS surveillance in Australia, more data is available from this website. Now, let me say something about drug policy in the two countries. The United States convened a meeting in Shanghai in 1909, which led on to a whole cascade of events resulting in global drug prohibition. And the US has been the major country in the world advocating an approach to drugs where this issue is defined in terms of it being a criminal justice problem. And the United States has really been largely responsible for disseminating this view around the world. 31 years ago, the first war on drugs anywhere in the world was launched here in the United States in the Nixon administration. The USA allocates 76% of resources, government resources in this area, to supply control and 33% to prevention and treatment. By contrast, Australia banned cannabis in the late 1920s, different states at different times, and Australia banned heroin in 1953. And this ban was, is suspected to have been introduced largely due to US influence, but that's not been proven. Australia allocates 84% to supply control, 6% to treatment, 10% to prevention and research, so quite a similar kind of spread to the United States. These figures are from 1992, the most recent available. Australia, but here's a big difference. Australia adopted harm minimisation with the Prime Minister and the equivalent of the governors of all states adopting this in April 1985 as the official national drug policy, and this policy has been reaffirmed several times since. And it was the adoption of harm minimisation which provided the flexibility of policy, allowing a very rapid response and a flexible response to the problem of HIV infection among injecting drug users. In 1991, it was estimated that Australia spent 10 million Australian dollars, that's 5 million US dollars, on needle syringe programs across the nation, and this saved an estimated 270 million Australian dollars, preventing an estimated 2,900 HIV infections. This was an independent report, not a government report. So the commonality is that both countries, Australia and the US, have relied heavily on supply reduction during most of the 20th century, but the difference has been, in terms of drug policy, that Australia's adoption of harm reduction in 1985 allowed a rapid and extensive deployment of HIV prevention measures to try and control HIV among injecting drug users. So, there's just one slide I've missed, unfortunately. And that is about HIV prevention principles. HIV spreading among and from injecting drug users has a much greater, disproportionate effect on public health than other risk groups. And this is not only true of health costs, but also of social and economic costs. And in many countries, injecting drug users have been the major HIV multipliers in their community. For example, HIV entered the injecting drug using population in Thailand in 1987, and within 5 to 6 years, in the northwest of that country, 1 in 6 male military recruits and 1 in 8 pregnant women were already infected with HIV, and almost certainly that was because of rapid infection through the injecting drug users in 1987, and almost certainly the injecting drug users in Thailand were largely infected through their prison population. The other points about HIV prevention in this population is that it is far more effective and cost-effective than with other risk groups. In fact, HIV prevention among injecting drug users is probably among the most effective interventions in the prevention and treatment repertoire for HIV/AIDS entirely. So it's a very important area to get right. So let me come to my conclusions now. Firstly, when we compare the United States and Australia, the commonalities outweigh the differences in national characteristics, in terms of drug use, and in terms of the early history of HIV. In terms of drug policy, both countries have emphasised supply control, but thirdly, the acceptance of harm reduction in Australia enabled the public health triumph of HIV control among injecting drug users and from injecting drug users, and this has been to the immense health, social and economic benefit of the country, and this triumph has been achieved at low cost. Harm reduction, which is present in Australia and absent in the United States, in fact it's regarded as almost a term of abuse in the United States, is really the most critical difference explaining the different course of the HIV epidemics in the two countries. Unfortunately, what's happened with harm reduction, with HIV infection among injecting drug users in the United States will be a tragic legacy that passed on to several future generations in this country who are going to pay a very high price for the poor control of HIV among drug users, which began in the 1980s. So I hope this comparison between the two countries will help us to illuminate where we should be going in drug policy in the future. Thank you very much.
Dr. Grabowski will have a question. Yes, surely. Yes, yes.
Early 70s, where amphetamine was unavailable very quickly, and cocaine came in as an available substance, albeit illegally. You noted that amphetamines are available in Australia, or rather that there is a larger abuse problem than with cocaine. Might be a transport issue, but what is your substance control policy with respect to amphetamines? Are they still reasonably widely prescribed?
No, they are available for specific indications for therapeutic use. They're widely prescribed for attention deficit hyperactivity disorder, as they are in the United States, and we believe that very little of that, if any, gets diverted to the black market. The black market is now supplied both from within the country and from Taiwan and Hong Kong, and that's methamphetamine. I
was not thinking of diversion to black market. I was thinking of a more liberal prescribing process which might permit people to use amphetamines as a social adjunct, as a quasi-therapeutic agent, not a diversion issue. And our rules are really stringent, and prescription has gone way down, and physicians are terrified of giving the drugs and so on. I mean, the medical indications like weight loss and the result, I think a lot of people were using them, and then cocaine took over, and I wondered if you have a different policy with respect to prescription of those agents that would effectively keep cocaine out as the drug of choice.
Amphetamine prescription to control amphetamine dependence is rare in Australia. There is some research in that area, which I've been involved in with colleagues, but this is a common approach to the treatment of amphetamine dependence in the United Kingdom, and there is increasing evidence of its benefit, and I believe that you've conducted some research here in Texas on this. And I think it's a very important avenue in the future. But this has not been, to answer your question directly, this has not been on a sufficient scale in Australia that could explain the differences between the US and Australia.
Other questions?
Jerry Epstein with the Drug Policy Forum. Alex, you've indicated from your figures that what we have here is potentially tens of thousands, maybe even hundreds of thousands of preventable AIDS cases if we were to use harm reduction principles. Could you give us some figure of the financial impact, the distinction between taking care of an AIDS patient over their lifetime, what that might save us financially?
Well, Ernie Drucker and Peter Lurie have done that in a paper that was published in The Lancet, and I'm sure that Ernie will remember those figures better than I can, and I hope he'll do that in a moment as he's coming to the microphone. But can I just say before Ernie speaks that, as I remember that paper, the estimates that these authors used to derive their conclusion were based on a series of 7 assumptions. And at each of those 7 assumption points, the most conservative estimate was used to feed into the final formula. So the estimate that Ernie and Drucker and Peter Lurie published in The Lancet is a very conservative estimate for the US, and the real figure, were we able to ever estimate that precisely, is likely to be very much higher. But I'd be grateful if Ernie could answer that question.
I had another question for reason for coming up, but it was about 20,000 cases in a restricted window of about 5 years. And so it probably by now would be 40,000, the exercise. We used Australia as the base comparison for what was possible to achieve through the early institution of needle exchange and syringe exchange, and the difference between what was going on there and what was going on here, and projected out the number of cases and the cost, and it's very substantial, obviously.
And the cost was hundreds of millions of dollars.
Yeah. My question actually was to ask if you could say a word about the process that led to the acceptance of harm reduction as a strategy as a national strategy in Australia, despite immense pressure from the United States over times against that, particularly in New South Wales, where you are with the drug summit and how that process. Because I've always been struck by that process being the ticket.
Well, the adoption of harm reduction in Australia in April 1985 derived from an unusual set of circumstances. In late 1984, the Prime Minister announced that he was closing down a judicial commission inquiring into corruption. And this had revealed a lot of corruption among very widespread in trade unions involved in the waterfront, and also much further in law enforcement, which was unexpected. When he announced this, he was accused by his political opponents in Parliament for shutting this down because he was trying to protect his own powerful friends involved in drug trafficking. Charming kind of political remark that passes in Australia. And the Prime Minister cried in Parliament when this criticism was made of him. And the next day, his wife, the Prime Minister's wife, went on national television to explain that her husband had cried because their daughter was using heroin, and he was so appalled that anyone could ever think that he would shut down a judicial inquiry because his friends were trafficking in drugs, and was appalled to think that that anyone could think that he ever had drug trafficking friends. So this led to a kind of national psychodrama, and very difficult to describe proportions. The radio, television, and the print media was just full of this day and night for 7 days a week, for weeks on a time. And this led to a real questioning about what the country should do about the drug problem. As it happened, a psychiatrist working in full-time for the federal government in the health department, responsible for drug policy, drafted a document on harm reduction. This psychiatrist is a member of the Salvation Army. He's never knowingly taken any mood-altering drug in his life, but is very committed to public health. Wonderful man, Dr. Les Drew. And he drafted a policy which rapidly went through the health department because doctors are very familiar with the concept of harm reduction in medicine, although we'd usually call it by different names. And there was a national summit of the Prime Minister and equivalent of the governors of each state on April the 2nd, 1985, and this was one of the policies that they considered that day, and they all signed the document to consent to that policy, to support that policy. And it's been very carefully evaluated ever since on several occasions by independent committees, and each time they've recommended strengthening the commitment, not weakening it. The 1999 Drug Summit that Ernie refers to was a watershed occasion which occurred actually in the New South Wales Parliament, and there was a conference similar to this occurring in the Legislative Building in Sydney. And when that conference took place, the parliamentarians were accompanied by about 80 delegates from outside who were treated as members of Parliament, the Speaker and so on, following parliamentary rules of some sort for a whole week. And we took part in that process. And during the mornings we had debates like parliaments do, and in the afternoon we did committee work. One morning, on the Wednesday morning of that week, went for 5 consecutive days, the members of Parliament were taken around to see drug treatment centres, and they were shocked when they saw the squalor of the public treatment sector. This whole week resulted in about 170 recommendations passing through the debating process, and all bar 2 of those recommendations were passed. And then when those recommendations finally went to Cabinet, Cabinet approved all of those recommendations except 2. So all of the 176 recommendations ended up being passed except 4. And this was a watershed, and it not just for the state of New South Wales, but also for the whole nation. And it has allowed us to move on and consider this much more as a health and social issue and less as a law enforcement issue. And that really is the critical divide in this whole area.
Thank you very much. Eugene Oscapella is a lawyer in Ottawa, Canada. His firm specializes in research about legislative, trade, justice, and social policy developments in Canada. And he's done extensive work on drugs and HIV/AIDS testing and medical, legal, criminal justice, and drug policy issues. Eugene served as a counsel to the Commission of Inquiry concerning certain activities of the Royal Canadian Mounted Police. From 1982 to 1985, he was Director of Legislation and Law Reform for the Canadian Bar Association, and he is a founding member of the Canadian Foundation for Drug Policy, which is the Canadian member of the International Foundation for Drug Policy and Human Rights, and a member of the Policy Committee of the Canadian Criminal Justice Association. Happy to have Eugene Oscapella to talk to us about the situation in Canada.
Thank you very much, Ambassador Durajan, Dr. Martin, and the Baker Institute. I'd like to thank you for the invitation to be here. As I'm delighted to be here because at these meetings I learn much more than I can impart by the way of information. I wanted to talk a bit about the impact of American drug policy on Canada, and I wanted to talk a bit about Canada. This is a statement by our beloved former Prime Minister. And Richard Nixon had a few comments about Mr. Trudeau as well. Mr. Trudeau, yes, Mr. Trudeau was not a communist. Now, we are a nation of 31 million people. We have a bicameral parliament, an elected House of Commons, and an appointed Senate, which has implications for the development of drug policy. We're cold. This is the summer cottage. These are the pet polar bears. These are our beloved police force, the RCMP, as depicted by Monty Python. And this is the Canadian economy. Essentially, we have a history of being hewers of wood and drawers of water for the American economy as a resource-based economy. But as you all know, we're a very lovable people, as Monty Python points out. Now, we're also a little bit different than the United States. We're neighbors, we're friends. I think we're brothers and sisters in many ways, but we're different in a lot of our attitudes. Our homicide rate, for example, is about 1/3 of that of the United States. We, like Australia, we haven't had the death penalty. We haven't had a public execution for over 40 years, although one might argue that some of our public policies amount to a death penalty in some situations, drug policy being one of them. Our incarceration rates are slightly higher than Australia's, slightly higher than most European countries, significantly higher than a few countries like Finland, for example, but they're about 1/6 the rate of the United States. All our drug laws are federal. We don't have a conflict between federal and provincial, our equivalent states. We don't have a conflict between federal and provincial drug laws. The main drug law, the Controlled Drugs and Substances Act, is the latest incarnation of a series of drug laws that began when we prohibited opium in 1908. We prohibited cocaine in 1911, cannabis in 1923. It was a solution without a problem. The first conviction for cannabis possession was in 1936, 13 years after we prohibited cannabis. There are no mandatory minimum penalties in Canada for drug offenses. So we don't suffer some of the problems that we see in the United States, and that has no doubt an impact on our prison population. The maximum penalty for offenses such as importing or exporting is life imprisonment. Now, life imprisonment in Canada means 25 years. The rate of HIV infection, new HIV infections attributable to injection drug use in Canada is about 34%. So we're fairly close to the United States, and we're nowhere near as good as Australia in dealing with injection drug use. But our numbers are coming down. As you can see, the profile of our charging practices isn't that different from the United States. Cannabis, over 2/3 of the charges in 1999, and about half of all drug charges in Canada during 1999 were for the simple possession of cannabis. Now, there's a lot of talk about we get lots of free advertising from the DEA and papers like the Washington Post and the Boston Globe about how Canada produces such wonderful marijuana, and it's a major export commodity to the United States. The Auditor General of Canada, which is the equivalent, I guess, of the General Accounting Office here, reported in December of last year that we supply actually only a small portion of the U.S. market for cannabis, but that doesn't stop the DEA nonetheless. We have problems with organized crime, intimidated police officers. About 2 years ago, we had a sitting member of Parliament put under 24-hour RCMP protection after he was threatened by motorcycle gangs in Quebec because he was trying to stand up for some of his constituents who were being coerced into growing cannabis on their farmland. There was very little outcry in Parliament over this. You know, we are one of the most robust democracies in the world, and here we've got a sitting member of Parliament being intimidated by organized crime, and the issue just went away. The official policy in Canada is that drugs are primarily a health and social issue. Health Canada is actually the federal department that is responsible for our drug laws. The Minister of Health is the lead minister on these drug laws, which of course can put you away for life imprisonment, which I don't think is very healthy. Despite our official policy being that the criminal law should be used as an instrument of last resort. That, again, is official policy. Drugs are primarily a health and social issue. The Auditor General of Canada reported in December of last year that about 95% of our federal expenditures, that's the federal government expenditures on drugs, were used for supply reduction. So, I mean, if the American figures are accurate, then at the federal level, we're even worse than the United States in terms of what we're doing. Now, there is some debate. This is Canada's equivalent of Time magazine. There has been a lot of debate in Canada over cannabis issues, and so it's sort of reached the popular press now, which is kind of nice. As we say, men die for it, women cry for it, and Ottawa debates it endlessly. But there have been some good developments. There have been a number of court challenges that resulted in access to medical marijuana. In one case, the Ontario Court of Appeal, our most populous, the Court of Appeal of our most populous province, actually declared the cannabis law, the possession law, unconstitutional, but it held the declaration of invalidity of the law in abeyance for 1 year to give Parliament time to get its act together. So Parliament came up with a set of medical marijuana regulations. So there are now about 600 people in Canada who have legal access to medical marijuana. It's about a 25-page form you have to fill out. Now, we can prescribe heroin and cocaine and morphine with much less rigmarole than that, but nonetheless, at least we're getting some access. And we have an abandoned mine in Manitoba, one of our central provinces, where I don't know how many 100 feet down we are, but we are growing marijuana. So we have a very secure facility in the country for growing marijuana, courtesy of the federal government. I think this was a little plum for the Manitoba populace to give them some employment there. We have, working right now, we have both the Senate and a House of Commons committee examining drug policy. And the mandate of both these committees is very broad. It hasn't been artificially truncated to just deal with peripheral issues. They actually are looking at the core issues. Next fall, there will be a constitutional challenge to the cannabis laws going to the Supreme Court of Canada. There is a bill right now, if I should have read that more carefully, a bill to decriminalize cannabis before Parliament right now. It's a private member's bill, which means in Canada that it probably won't get passed. We have legal syringe exchange programs, legal and funded by government. We have safe crack kits as well in some parts of the country. We even have methadone in prisons. We have methadone programs in other parts of the country. Several weeks ago, 20 big city mayors, now big city in Canada means a city of 100,000 or more, but basically 20 big city mayors unanimously agreed that they would support safe injection sites in Canada. Okay, this was at the behest, this was a resolution put forward by the mayor of Vancouver, which is probably the epicenter of the drug problem in Canada. The former Minister of Health a few months ago gave his support for safe injection sites. The Fraser Institute, which is like a Canadian version of the Cato Institute, basically a free market think tank, came out with a report last August saying the war on drugs is a colossal failure. Or it wasn't actually its report. It published a series of policy papers to that effect. So we're getting somewhere in terms of the public discourse on drug policy in Canada. We have restrictions on legal drugs. There's no tobacco advertising allowed in Canada. We have even restricted sponsorship of cultural events and things like that. So we're getting quite strict about that. We don't allow direct-to-consumer pharmaceutical advertising, and the Minister of Health, formerly the Minister of Justice now, has just said that no, we are not going to do that in this country. There is going to be support for pilot heroin maintenance programs in Canada as well. So I think you can see we're looking a lot towards Europe. There's very strong resistance in the country to workplace and school drug testing. There is no school drug testing in Canada that I'm aware of. Now, we have drug dogs sweeping through the schools, and a couple of weeks ago, a kid was kicked out of school because the dog smelled cannabis on his jacket, and even though he had no drugs, and a search revealed no drugs, and there was a big kerfuffle over this, and he's now back in school, and nothing has happened as a result of it. Workplace drug testing in Canada is often driven by American parent companies who believe that they can impose drug testing in Canada the way that they have in the United States. In fact, they can't. Canadian human rights legislation has been used as a sort of a stop to drug testing. It's been quite effective in that. So we have transportation workers who enter the United States. They have to be drug tested. And that's fair game. If they're going into the United States, and if that's your policies, we do that. But basically, we've managed to keep drug testing at bay in Canada. And like the United States, and like we saw this morning in USA Today, the smugglers refine tricks to pass stricter security. Our drug laws don't work. Total inability of law enforcement to suppress the drug trade. We stop about 10% of the drug trade. That's the estimate in Canada. So we realize that more and more publicly, we see what's happening in Canada, we see what's happening in the United States, and we recognize that it just doesn't work. Supply reduction just doesn't work. Now, U.S. influence. This is our former Prime Minister, and his wife, this is Brian Mulroney, Mila Mulroney. This was 1985 at the Shamrock Summit in Quebec City. You'll love Quebec City, Judge Gray. I think they were singing Danny Boy at that point, or When Irish Eyes Are Smiling. A very strong relationship between Brian Mulroney and former President Reagan. President Reagan declared a drug epidemic in the United States I think in 1986, and a few days later, Prime Minister Mulroney declared one in Canada. Now, we had a bit of a problem because we didn't have a drug epidemic, and we had to create a national drug strategy. And I remember calling then, and of course we announced the national drug strategy, and I called Department of or Health Canada to get a copy of the drug strategy, and they said, well, we don't really have it yet. So they had to develop a drug strategy. And when they developed the drug strategy, it was very weasel-worded because it was expressed in terms like people perceive that there is an increasing drug problem in the country. And that was the sort of justification we used. But there are other influences that are more direct on Canada. First of all, we get a lot of the anti-drug advertising that you get. I mean, we see some of those same silly I use drugs and help kill a judge ads that the DEA is doing. We get the Partnership for a Drug-Free America ads, that sort of propaganda. We see the same sitcoms that were played using scripts that had been sort of vetted by the drug czar's office. This was uncovered by, I believe it was Slate magazine in about 2 years ago, that the drug czar's office was sort of trading advertising spots for if the various programs gave the right anti-drug message in them, unbeknownst to the people who are watching the programs, then the networks wouldn't have to show as many anti-drug slots. So of course that would save them advertising dollars. The DEA is in Canada. They've opened up some offices. Now this is nothing untoward. We have offices. The RCMP has liaison people all over the world, but the one that opened up in Vancouver recently, the head of the office said that this is going to be a more substantial operation. It's just not going to be a liaison operation. And in fact, we've got the DEA. I have one newspaper, an account of a DEA officer working undercover on a Canadian drug bust. And we also find out that the CBC, Canadian Broadcasting Corporation program, reported that the DEA was paying informants in Canada, which sounds an awful lot like paying foreign agents in a foreign country, but it might be something we want to look a bit more closely at in terms of international relations. The U.S. Department of State has been very critical of Canadian courts, which again is a bit of an affront to Canada. They've criticized our courts. They've said that the Canadian Supreme Court has actually had the gall, in essence is what they were saying, to go ahead and say that constitutional rights would be allowed to interfere with some sorts of undercover operations because of our Charter of Rights. And that concerned them. They were also concerned with the apparent lightness of sentencing in British Columbia, to which the Chief Justice of the BC Provincial Court basically told the United States to butt out of his business, saying, if you guys are so good at solving the problem, we might pay more attention to you, but we'd rather pay attention to somebody who's got the answers. But there is also a homogenization of thinking on drug policy issues. And our police come down to the United States for conventions, and they see your guys, you got bigger guns and fancier equipment and more money. And those attitudes, those sort of influences, they're subtle, but they're there. So there's sort of a homogenization of thinking coming from this. As I said, we don't have workplace and school drug testing, but we're seeing some of the rhetoric in the States. We are getting drug courts. Now, drug courts can be both good and bad. It depends how they're used, and I think as Judge Gray recognizes that there's a good way to use them and a bad way to use them. We're still waiting to see how they're going to be used in Canada. What we're afraid is that they're going to be used to justify not taking other measures. That's one of the concerns we have, is that the government will say, well, look, we've instituted drug courts in several cities across the country. Now we don't need to act on some of these other more substantial measures. What is the behind-the-scenes pressure in Canada by the United States? I have no idea. We just lost a trade dispute with the United States over softwood lumber. The other major export we have from BC is softwood lumber, the first one, of course, being marijuana. So now, was our loss in the softwood lumber dispute sort of a quid pro quo for our apparent lack of concern about marijuana exports to the United States? I don't know, but I suspect that if more people are going to be out of work, if they won't be, hewing wood and drawing water and shipping those things across to the United States, that they might perhaps get more involved in a bit of drug trafficking themselves. There's also a conference that's going to be taking place in Vancouver in a couple of weeks. And this is and what they say is, harm reduction has been a major failure. In Canada today, the harm reductionists have dominated national, provincial, and local drug policy decisions. I wish. But their false promises threaten the well-being of our children and our society. Well, look at who's funding this thing. Presented by the International Drug Education and Awareness Society in partnership with Drug Free America Foundation and Drug Prevention Network of the Americas. So we're seeing, I can't help but think that this is an attempt to derail the safe injection sites, the heroin maintenance programs that are being planned in Vancouver. So where are we going in Canada? Well, we're seeing the great, as Milton Friedman says, the great socialist American war on drugs, this great socialist enterprise. Nobody in Canada thinks of the United States as a socialist country, certainly, but when you look at the war on drugs, what is it but a colossal socialist enterprise? We are looking away from that. We're looking more towards Europe. I don't know how much the statement that the United States won't let us do this is an excuse that Canadian politicians use, or whether it's based in reality, in actual fact. But we are looking towards Europe. I just wanted to say a couple of things about terrorism. I watched the rhetoric. I'm doing a study. To its credit, our Department of Justice has actually allowed me, a rabid anti-prohibitionist, to do a study on the links between drug prohibition and terrorism. Drug prohibition, I say, not the drug trade. But we keep on speaking about the links between the drug trade and terrorism. And look at this. This is an ad for the Drug Enforcement Administration for a conference held in December of last year to talk about the drugs and terrorism. And as you can see, you've got this guy. He doesn't look like he's from Afghanistan. They were very polite about that. But he's got a bomb in his hand, a wad of bills in the other, and he's sprinkling drugs and injection equipment on people. And you see a map of the United States. Frankly, I think he's sprinkling the stuff on Canadians, but because I think he's a bit north of the border. But that's the image. This is a sort of a repeat of the First World War scares about the Huns poisoning people and the scares during the McCarthy era of Red China poisoning people with drugs. But this is the attitude. But I want people to look at this notion of why drug prohibition is the problem. It's not the drug trade. It's the drug trade under a system of prohibition. Take a kilo of opium, which is worth, convert that to heroin, that's about 10 times, takes about 10 kilos. So what would be a $900 cost of production at the U.S. retail level is almost $300,000. 322 times the farm gate price of the opium. That's prohibition that's doing that. Opium wouldn't be financing terrorism to any significant extent if it weren't for prohibition. We are giving organizations that want to destroy us the money to do it through prohibition. Very simple point, economics 101, and it's totally ignored by governments. Without prohibition, the drug trade would not be a factor in terrorism. Because of it, the drug trade is a major source of terrorist finances. We can't, it's as simple as that. It really is as simple as that. How much longer are we going to go feeding money to terrorists? That's not the only source of income for terrorism, clearly. It's a major one, and it's an easy one. So, this is at the end of the day, we're all victims of our own folly. Thank you.
Thanks very much, Eugene. We're going to hold questions on this. We are going to have a chance this afternoon for a more extended discussion session. We want to try to keep on schedule here. But thank you very much for extremely well done presentation. Peter Cohen is a sociologist and social psychologist. He is a director of the Center for Drug Research at the School of Social and Behavioral Science at the University of Amsterdam. And in 1983, Dr. Cohen designed the research program on drug use epidemiology, drug use patterns, and drug treatment evaluation for the city of Amsterdam. He's the author of numerous articles and on drug use and drug policy. Yesterday, Marsha Rosenbaum spoke of San Francisco as the Amsterdam of America. Well, we all know that the Netherlands have a drug policy rather different from our own. One hears various things about this policy, some of it accurate, some of it not, and about its results. If you have questions about it, I think it's fair to say that no one is more qualified to answer them than the man in charge of collecting and analyzing the data, Dr. Peter Cohen.
Thank you for having me here. It's a very interesting conference, and as Kevin Z said, it's time to have dialogue between prohibitionists and anti-prohibitionists. The origins of modern Dutch drug policy were laid in the 60s, when a coalition government between the socialists and the Christian Democrats was in power, and in the 60s, cannabis use became fashionable in mainly the big cities. Originally, cannabis was a threat to society. It was perceived as such, both by the Christian Democrats and the socialists. But very quickly, at the University of Amsterdam, research started into use patterns and what type of people were using marijuana, and a discussion ensued which led to a few commissions to look into this problem of cannabis use. And both commissions concluded that on the basis of research, the period of use was relatively short. The integration of use into into a much more complex lifestyle was seemingly unproblematic, and it was decided that individual drug use and small-scale dealing of cannabis would be left unpunished. So in '72, when the two big committees concluded their work started to change the legislation and make it possible to not punish cannabis-related trafficking, small trafficking, and consumption. This work was ended in '76, but already before '76, let's say from '72, '70 on, the decriminalization of cannabis was already part of the Dutch discourse. The reality of decriminalization appeared above all in the allowance of cannabis being traded and used in government-subsidized youth clubs. The so-called club dealer found its way into Dutch subcultural life. Many youth clubs and music clubs introduced their own club dealer where you could buy small quantities of cannabis. Some of these club dealers in the early 80s wanted to start for themselves, and that there is the foundation of the so-called coffee shop. Coffee shops were institutions for which you did not need a license, and so they called their cannabis shops coffee shops because you could sell there juice, coffee, and also cannabis. So the institution of the coffee shop is a kind of privatization of government-allowed club dealing. The use of cannabis was quite unknown in the 60s, Actually, there were some youth surveys going on. Population surveys only started in '87, when the University of Amsterdam started to survey the population of Amsterdam, and we have done this ever since. In '97, we did the first national survey, and I'm going to show you some data from those surveys. There have been some changes in cannabis policy. As I said, the origins of the cannabis policy were laid in the 60s and 70s when there was a coalition government between the Socialists and the Christian Democrats. But in 1994, the Christian Democrats started to be part of the opposition, and from that moment they also started to oppose the existence of coffee shops, and they do ever since. So it is now part of Christian democratic policy to oppose coffee shops. In the small amount of time that I have, I will discuss policies around ecstasy and heroin. Heroin started to be part of the scene in the early 70s. It was brought in by American GIs working in having holidays from Vietnam. And it quickly became fashionable among a particular part of the population. And it created a lot of concern. And the city of Amsterdam initially didn't really know what to do. Basically, heroin use was an Amsterdam-based subculture, later spreading to other cities, and sorry. I have to stop this.